Hello and welcome to my seminar on Polycystic Ovarian Syndrome. I'm Dr. Andrew Chappell and I'm going to be presenting this presentation for you today on behalf of the Clinical Nutrition module. So let's get right into this. So throughout these slides you're going to see lots of useful information put up on here. So this slide here has got the coat of arms. This is the Royal College of Obstetrics and Gynaecologists. So there's lots of useful information that you can find on that website related to this particular topic. Okay, what we're going to do in this session is we're going to do a few things. And hopefully by the end of this session, you'll have got out of this the ability to be able to describe polycystic ovarian syndrome. From here on out, I'm just going to call it PCOS. We're going to talk about the pathophysiology, how it happens, how it occurs, what's going on with it. We'll describe how we manage PCOS, and I'm also going to talk about some of the research and nutritional approaches around PCOS as well. Throughout this presentation as well, the version that you're going to get, there's lots of these links. You can click on these links and then you can follow up on any of the materials that you'll see produced on this presentation. So, first off, I want you to have a think. So you can stop this presentation right now, if you'd like, and think about this. PCOS is a syndrome that affects the reproductive organs in adult females, but also adolescents. And because it affects the reproductive organs, have a think about how that potentially manifests physiologically, what happens, and what are the consequences of this. So if this is a syndrome that affects reproductive organs, then you might want to start thinking about, well, potential fertility issues going on in the future, just as an example of this. So pause this recording, have a little think. Okay. So you've had a little think about this, how it affects the reproductive organs. So first and foremost, what is PCOS? And you can see from this nice diagram here, I've got on my left-hand side, on the right-hand side of the page, what we have is a normal ovary, okay? Now, in a polycystic ovary, what we have is we have excess amounts of follicles, and these follicles are where our eggs are produced and released, okay? So we've got an excess amounts of these follicles. However, having excess amounts of these follicles is not enough alone to define someone as having, or some women as having, polycystic ovarian syndrome, okay? So what we need to have to be defined as polycystic ovaries syndrome is a combination of clinical and biochemical hyperandrogenism. So if you imagine androgenism as in the male, you might see clinical symptoms whereby women have additional thick hairs on their arms. They might be having male pattern baldness, hair on their face, acne, for example. Another syndrome they might have associated with PCOS is ovarian dysfunction. So in this example, they might suffer from amenorrhea, loss of the menstrual cycle, oligomenorrhea, an infrequent menstrual cycle, an unpredictable one. And then I've mentioned already about the polycystic ovaries themselves, okay, as defined by using something like an ultrasound or by you looking at anti-Mullerian hormone, AMH, okay? And again, as I say, it's not enough to have just the enlarged and extra follicles alone. We need to have 2 out of 3 symptoms for us to have a definition. Now, whenever you think about syndromes, it's important to realize that in science, what we often like to do is we like to put things in boxes so that we can easily define them, okay? But with PCOS or anything which is called a syndrome, often that's the case of there are multiple factors which contribute to something have an overall expression in terms of a phenotype. So you see expression of particular patterns, which could be the combination of lots of different things, and we don't quite have a handle on what the different things are which contribute towards that. So they go under these sort of broad umbrella terms like syndrome. So it's heterogeneous. There's lots of different phenotypes that can contribute towards these definitions. Okay, so you were thinking from your 5-minute example, and I've given you a couple of things which can happen already. So things which occur as a consequence of PCOS. So we see things like dermatological issues because we've got increased amounts of androgens. So the male hormone testosterone is increased in this condition. So we see acne, we might see alopecia, we might see hair growth on the face as a result. There are cardiometabolic consequences as well. So obesity is common, insulin resistance is common, hyperinsulinemia, dyslipidemia, that low-grade inflammation, systemic inflammation that we often see associated with obesity is present as well. In terms of reproduction, I've mentioned already, we see the polycystic ovaries, we see oligo and amenorrhea, but we can also see things like fertility issues, difficulties becoming pregnant. And then there's a whole host of psychological well-being issues which are coupled with these different factors as well, but women might be suffering from anxiety, depression, low mood, etc. And some of this can be as a consequence of having lower amounts of estrogen within their body and an imbalance in their hormonal profile, rather than an indirect effect of these other things as well. So because of the number of potential symptoms, it can be difficult to diagnose. You can also misdiagnose as well. So someone might have obesity and have a number of these different issues, but not have PCOS in any way at all. It's just a combination of factors being driven by the central obesity, if you like. So it makes it challenging. So in terms of the prevalence, this is a study here that I pulled up that looks at 157,000 participants. It's 92 different studies, and it looks at prevalence of PCOS around the world. And you can see we've got data for the Americas, there's data for the Western Pacific, Southeast Asia, we've got the European plain, we've got the East Mediterranean going into the Middle East. There's a lack of data you can see here for Africa. But generally speaking, you can see prevalence rates, they go from 7.8%, that's the average, up to 12.1%. If you look at the far range in data, you can see as much as 17.9% as well up on the higher ends. If we're looking at places like Southeast Asia, again, we've got, if you look at the graph here, the graphic, the range here goes as high as 25.9%. Now, much of this depends on how you define PCOS. So if we use our criteria, which is that we have to have 2 out of the 3 potential symptoms, then we can define it this way. However, we're defining it in different ways. Perhaps if it's self-reported, you might see higher or lower prevalence within this on here. So this does affect a lot of women, And I've seen some studies that suggest up to 70% of women who have PCOS go unreported, okay? So that's up to 70% of women that have it. That's not 70% of women have the PCOS itself. So that's an important distinction. In terms of diagnosis, this is what we're looking at here. So again, it's if we're using ultrasound, and you can see the image here, we've got the normal ovary here in the cartoon diagram. And then you can see a polycystic ovary here. It's got much more of these follicles, many more of them, and they're larger in scale. Under an ultrasound, we can see the image to my right. We have got what we describe as a normal looking ovary on here. And then we've got one on the left, which has got more follicles within it as well. We're looking at having 20 follicles or more, measuring between 2 to 9 millimeters, okay? So if we're falling within that category, then we can say that someone has at least one of the symptoms of PCOS on here. We also, again, we can look for elevated amounts of murinin hormone, so AMH as well can be another factor that we're categorizing here. Now, it's possible to have more follicles within that criteria, but not have any of the other two factors as well. That's important to realize. Just in the same way that it's possible for someone to have oligomenorrhea, described here as oligovulation, or anovulation, the complete loss of the menstrual cycle without having PCOS. Right? That is possible. But these are, again, contributing factors. So, what do we mean by ovulation or oligomenorrhea? Well, what we're talking about is infrequent or irregular cycles. Typically, you're looking at maybe fewer than 8 cycles a year, okay? They still happen, they're just irregular. In fact, they could go up to 45 days, if you like. The problem with this is, of course, that if we've got decreased amounts of ovulation, there's fewer eggs available, there's much less chance of becoming pregnant. On the other side of things, we've got anovulation or amenorrhea, and this is the loss of the menstrual cycle. So there's no menstrual cycle at all, and when this happens, there's no chance of becoming pregnant. It's very irregular, and in fact, when periods do occur, they're very, very heavy as well. Again, things such as stress can cause this to happen. Very low-calorie diets, very low body fat levels can cause this to happen. So not necessarily always a symptom of PCOS, which is occurring, but it's one of our cycles. How would you know? Well, you could track it. So we've got an app up here. I'm sure many of you have heard of this. This is called Clue. This is something that I use with my female clients just to make sure that everything is functioning as normal, because many of them embark on extreme weight loss diets, and we want to just make sure that everything is ticking over and that we're tracking data in that respect as well. Okay, final characterization of PCOS is this idea of hyperandrogenism. Okay? So that manifests physically, it's expressed as acne, hirsutism, alopecia. So we're seeing male pattern baldness, we're seeing acne, the skin might change a little bit more to be like men's skin. Alopecia, again, the male pattern baldness, hair growth on the face, thicker hairs on the arms as well, yeah? The reason that this is happening, is because there is a change in the amount of testosterone or free testosterone androgen, DHEA, these are all hormones associated with testosterone. In fact, these are pro-hormones which eventually go on to be converted into testosterone. You see the same thing in women who will take testosterone, maybe in athletic sports, for example, against the rules, but they sort of will experience symptoms associated with this. So you can measure these things biochemically, but you can also see some of these things manifest physically as well. So we're looking for 2 of the 3 criteria. There are other factors, though, that you might want to consider if we're looking at PCOS. So if someone has a family history of PCOS, if it's been diagnosed based on the previous criteria, then it's quite possible that they're also potentially suffering from PCOS or have PCOS if they only have 1 of the 3 symptoms, or if they have 2 of the 3 symptoms and they have a family history, then you can probably be even more assured that you're seeing PCOS being present. Insulin resistance, obesity, and central adiposity in particular is also associated with PCOS as well. So it can give you more clues associated with what's going on. However, as I mentioned previously, being insulin resistant is often associated with adiposity, obesity, and is linked to some of those other characteristics as well. Now I'm going to try and pronounce this one. Ankyphosia nigricans. I didn't get anywhere close to it, and that's the last time I'm going to do that. This is a skin condition, and you can see it characterized here on my right-hand side on the screen. And this is whereby women develop a rash around the neck, around the genitals, around the armpits. You can see it's wart-like in its appearance. This is often a sign associated with PCOS as well, yeah? In adolescents, symptoms are similar, okay? But it's important to give it time in adolescence, okay? So consider investigation after 1 year, and bear in mind that the use of the contraceptive pill can potentially mask some of the symptoms of PCOS because it suppresses hyperandrogenism, okay? So that is an important factor we have to think about as well. Okay, so what causes PCOS? Well, it's multifactorial. So like I said before, when we have these syndromes, and as scientists we always like to try and put things into solid bins so that you can easily define things. But with a syndrome, it's very often the combination of different factors which are going to contribute to the PCOS. And it almost becomes a bit of a chicken and an egg type scenario. So, if you have poor diet and lifestyle, this leads to insulin resistance, which can lead to potentially PCOS, because we see things like dyslipidemia, we see things like obesity often being associated with that insulin resistance as well, or a contributing factor on there, and that can cause a suppression of things like estrogen, and it can cause our hormonal function to potentially get out of whack. We can see fertility issues at the same thing, and then it's a case of that can potentially contribute to PCOS or PCOS-like symptoms. Likewise, we can see the reverse as well, whereby we have a suppression of the body's natural estrogen levels, and we can maybe see an interference because of genetic factors associated with PCOS, which influence insulin sensitivity as well. So it's a kind of a what comes first type scenario because it can influence both. We've got microplastics, environmental toxins, pollutants, etc. might all contribute towards hormonal imbalances. Certainly we see more luteinizing hormone reduction than follicle-stimulating hormone. We might see an increase in testosterone production again, putting out of whack our natural amount of estrogen that we've got, contributing towards our hyperandrogenism. People like to talk about the gut microbiota. Certainly, poor quality diet can influence the microbes that live in your colon. They can then potentially have an influence on the hormonal balance within our body as well. Having worked in that area, some of these ideas sometimes I think are a little bit trendy, but let's not rule it out as well. The consequences of PCOS, again, reproductive issues, clinical features, metabolic features. I've discussed some of these already. There is a genetic component, as I've mentioned already. So as things stand, here are all genes associated with PCOS, which contribute towards ovarian and adrenal steroidogenesis, so maybe the production of estrogen and testosterone, contributing towards insulin's actions, gonadotropin regulation, so that's follicle-stimulating hormone, luteinizing hormone again, which are being secreted from the pituitary gland as well. So people have researched this, and they've found that these genes might be elevated, switched on, switched off, under conditions whereby people have PCOS. So it's not all just an environmental factor. It's not the fact that we always have obesity, for example. There is an underlying genetic potential cause. One thing that I've got on this slide here is about the associated hyperinsulinemia, or the insulin resistance that's often seen in PCOS. A potential link within this is it causes a reduction in something we call serum binding globulin, or sex hormone binding globulin, SHBG. And what this does is we've got a certain amount of circulating testosterone around the body. SHBG binds to that testosterone to regulate how much active testosterone you've got. So you might have a whole load of testosterone, you might have a whole load of bound testosterone, but it's only that free testosterone which is going to be biologically active. So if we see a reduction in that SHBG, then we have more free testosterone, and in the female body, this is where we get those clinical symptoms as a consequence for this. So that's the action of that hyperinsulinemia, insulin resistance, eventually potentially type 2 diabetes, contributing towards a negative impact on our reproductive organs. It's a cycle though, and they all factor into each other. So if we've got, starting down on the bottom right of our graphic, excess body fat. Excess body fat, particularly again that central adiposity, leads to issues with gonadotropin hormones being synthesized and impairments there. So we see less estrogen being produced. As a result of that, we might lose some muscle mass. But estrogen is important for ensuring that we've got insulin sensitivity, so we see a reduction in that. It has a knock-on effect on insulin resistance. Insulin resistance is compromised. After that, we see changes in the normal hormonal pathways, our metabolic profiles, so we start to see things like dyslipidemia as a consequence of this. We might start seeing increases in cortisol as a consequence, and then a reduction in estrogen as a result, which then ties into, again, more excess body fat being produced, and we've got this negative feedback loop going round and round and round again. So again, when we're looking at biochemical markers of PCOS, we're seeing things like disorders in the amount of estrogen being produced, disorders in the amount of follicle-stimulating hormone being produced as well. Excess body fat that we're going to be able to look at, so you can measure that with things like body composition analysis, but we can also see more lipid in the bloodstream as well. There's more factors as well. I've put this up here really to sort of emphasize the additional complications that we see associated with PCOS as well. So there's leptin abnormalities as well. So you're seeing things like people's ability to regulate their appetite is influenced as well. Dopamine metabolism you see here is impaired. Acetylcholine metabolism is impaired as well. So your ability to send electrical signals through your body because these neurotransmitters are compromised, are influenced. The little graphic I've got down here, not on the page, but what you can see is sleep disturbances are also common associated with PCOS. And if you want to read more about these, then you can follow the little link we've got down at the bottom of the screen. So with that in mind, how do you go about managing PCOS? If you go onto the NHS website or the Royal College of Obstetricians and Gynaecologists, you'll see recommendations like this. So, we know that there are modifiable risk factors which can certainly help reduce some of the symptoms associated with PCOS and address some of the potential issues. So, reducing body weight, particularly that central adiposity, is an important factor. Smoking cessation, reduction in total number of alcohol units, managed with healthy lifestyle, e.g. diet, increased physical activity and exercise, to try and reduce the potential for things like type 2 diabetes, cardiovascular disease, and to potentially reduce things like menstrual irregularities and other potential fertility issues. And this is just generally good advice for most people beyond just PCOS. With that in mind, it's important to understand that with this syndrome, or any syndrome, be it cardiovascular disease or irritable bowel disease, or IBS, irritable bowel syndrome rather than inflammatory bowel disease, that healthy organisms are always better at coping with physiological stress and psychological stress rather than unhealthy organisms, okay? So even with diseases or syndromes, if you put yourself at a healthier body weight, if you take part in regular exercise, typically you will cope better with managing these things than if you were not to do those sort of things. So again, alluding to in the last slide, this is just sort of general good advice. But in terms of the diagnosis, rather the management of this, important things to do. So if we encounter a woman that has PCOS, it's important that we let them know what the potential long-term consequences of this are. So if hyperinsulinemia is not addressed, then this can potentially lead to things like type 2 diabetes mellitus. If that central adiposity and dyslipidemia is not addressed, then we can see things like cardiovascular disease. Issues with excess amounts of testosterone, suppressed estrogen, having excess follicles, amenorrhea, oligomenorrhea can lead to potential fertility issues and an inability to get pregnant. So these are serious considerations. Healthy lifestyles can improve many of these issues. And if we're encountering an overweight or an obese woman, the general advice is to offer weight loss advice or to consider referral. Explaining that this might reduce some of the issues around hyperinsulinemia and androgenism. Might reduce issues around cardiovascular disease, type 2 diabetes, and infertility issues. Moving on for that, we're looking to screen. So we're looking at impaired glucose tolerance. We might do a test like an oral glucose tolerance test. Look at cardiovascular disease risk factors like blood pressure. Asking about sleeping patterns is important as well, because someone might have sleep apnea as well, and that might be something that we can address at the same time. And I believe you've already studied many of these sort of topics already, so let's look at the clinical skills topics for that one around weight loss, etc. Advice around adolescents is the same. So we're looking at doing similar things. Yeah? You might want to refer onto a pediatric specialist, though. That's what I would potentially say. Okay. Much of the guidance around PCOS and its management revolves around weight loss, screening, to try and address the symptoms, the causes of PCOS, yeah? But the question is, how good is this advice? So, this is a massive document produced in collaboration with the Royal College of Obstetrics and Gynaecologists. And it's a document which looks at the evidence base for the management of polycystic ovary syndrome. They've got an app. You can download this. You can ask it, how good is the advice around exercise or nutrition or specific diets or bariatric surgery or metformin in relation to PCOS. And it's a huge, huge tome. It's a massive document. Massive, massive document. You can get the link on here, so you can look at your leisure. And what they've done is they've produced some guidelines. Okay? So they've got their consensus group together of 50 scientists or 60 scientists from all over the world and other stakeholders that you've seen on the other page, which sponsored the creation of this document and provided grants for this and helped put the app together. And they've categorized them as 3 different sort of areas. So they've said that EBR, if you see someone with that next set, that means that there's probably an evidence-based recommendation. That they can make a recommendation around this idea of maybe losing weight to help manage PCOS. There's a consensus recommendation, so that's whereby there's not great evidence, it's okay, but a consensus generally is we could probably offer some sort of advice which is informed to the general population around this. And then there's practice points. So this is probably your lowest form of evidence. And these are things which have cropped up that have maybe been discussed in doctors' offices or came up during studies or focus groups, which they think are worth exploring in the future. But there's maybe not any evidence for it at this moment in time. Again, going through this document, they've graded it. So they've said, okay, there's 4 stars, 3 stars, 2 stars, and 1 star. And this is where they've said, yeah, you should absolutely recommend this advice to a potential patient. 3 stars, you could recommend that under certain conditions, and then so on, it gets weaker after that. Again, the evidence that contributes towards those recommendations is also graded, and it goes from very low to very high. So if it's very low, that might be because the evidence quality is just not there. There's maybe 2 or 3 studies done on that. They're all completely different. The methods they use weren't that great. It's maybe self-reported rather than anything absolute. So it gets a lower grade compared to something that we absolutely 100% know, bang to rights, that that's going to do something. So what does this all mean? Oh, the graphic's a little bit off there. Well, you get recommendations like this. So this is around looking at the biochemical hyperandrogenism. So this is looking at things like testosterone, DHEA, androstenedione, serine hormone binding globulin, DHEAs. If you use these things as screening tools, is it recommended? Is the evidence good? And you can see at the top here, what we're suggesting is that there's evidence-based practice that professionals should use total testosterone and free testosterone to assess and help in their diagnosis for PCOS. And we're pretty sure that's good practice. We've got 4 stars, but there's very little evidence to support it. So there's not a lot of studies going around that, but we're pretty sure it's a good idea, at least. And you can see if you go through the other ones, you've got other examples. Which throws up a few sort of considerations as nutritionists around, should we be getting people to follow specialist diets around the management of PCOS? And look, you don't have to go very far on the internet to find specialist recommendations around PCOS. So 2 minutes of searching, we've got the PCOS diet plan. You've got my 5 favourite exercises for PCOS: lunges, push-ups, group workout, squats, walking. This is the way to manage your PCOS. It's not bad advice. This BBC News report, you can see here are supplement regimes you should be following to manage your PCOS. I think this report said that people were making thousands of pounds by coming up with these diets and saying, as an influencer, you should follow it. But is there an evidence base for this stuff? Not sure if influencers really care. Well, around diet, nutrition, the guidelines from this large consensus document more or less say that there's no evidence to support any particular diet for PCOS, for managing hormones, for managing weight loss, for managing psychological or reproductive options, beyond general healthy eating advice. So there's not really an evidence base for this. But what's the rationale? Why would I follow a specialist diet? So here's some examples. If we look at fat manipulation, we've got cholesterol. And you can follow these biochemical pathways all the way down if you want. Cholesterol eventually gets converted into estrone and then estrol and then estrogen or aldosterone or cortisol or testosterone. So if there's a lack of fat in the diet, we could see a negative effect on our estrogen production. So maybe we should have a high-fat diet, or maybe we should have a low-fat diet. Which is it? And on that, maybe animal fat is better. Maybe it's the saturated fat we need. Saturated fat contributes towards testosterone production. So actually, maybe that's bad. Maybe it's a high monounsaturated fatty diet we need. And that's a plant-based fat diet. So maybe a plant-based diet is better. But what does the research say? This is the sort of thinking these diets go down. Here's a study published on this. This is a research article, which was a meta-analysis, which looked at different types of high-fat diets and their effect on PCOS. Okay? I looked at more up-to-date studies in this, but this has got a nice representative angle, right? And what it kind of concluded was, a high-fat diet with and without obesity may lead to insulin resistance, increased leptin, which negatively affects estrogen production. So you can see here we've got an ovary, we've got the high-fat diet leading to an increase in insulin and leptin, we've got multiple signaling pathways, but ultimately what's happening is we're seeing aromatization going down, which leads to a reduction in estrogen. Yeah? So maybe it's good for men because they want to see a change in aromatization. They want the aromatization going down so that it can keep more testosterone, because aromatization is whereby the testosterone gets converted into the estradiol. So if we reduce that, we see more testosterone. So that's a negative potential effect. However, this research area is not that rich. There's a lot of studies being done on mice and rats. Not so much done on actual adult female humans. Okay? And then we've got more issues as well, which is how much fat is a high-fat diet? Is it 35%? Is it 40%? What about protein? How does that influence it? And what about the type of fat as well? So we have to consider these things. But at the moment, it seems like a high-fat diet can't really support it, nor can we really exclude it. What about phytoestrogens? We've all heard of these. These are plant phenolic compounds, phytochemicals, which have an affinity for estrogen receptors. So they've got similar estrogen-type action to the actual hormone itself. They don't fit exactly 100%, but there's affinity nonetheless, as you can see from our lock and key cliche in biology. So we've got estradiol here, we've got isoflavin. This is a phytoestrogen, similar in its shape. And the idea is that a diet rich in these phytoestrogens may reduce LH, FSH, follicle-stimulating hormone, luteinizing hormone. We see a reduction in some of our gonadotropin hormones, so things like testosterone production being reduced, leaving our body open to produce more estrogen. That's the idea. Does it work though? Again, here's a study looking at this, published 2024. If you go through this stuff, what you see is there's lots of alternative treatments, but a lot of it's been done in vitro. So it's been done on cell lines. Take a couple of cells from an ovary, put some phytochemicals on it, see what happens. Estrogen production goes up or down. Great. What happens then when you put it in a mouse, into an actual system? Do you still see the same thing? Maybe you do. But what happens when you put it into free living human beings? How much do you need, and does it work? A lot of the research is in vitro, it's in mice. And the problem that we have with human beings is that when you look at what happens in the actual gastrointestinal tract, as soon as molecules get absorbed in the digestive system, they pass through the liver, and they're altered. They change the shape. Do they have the same bioavailability after that? Can they do the same function as they did before? They've been changed somehow. And they're very often excreted quite quickly, right? There's also issues around the magnitude of effect. You can put on a cell line 100 mgs of that stuff. You might consume 100 mg of the stuff, but maybe less than 1 mg actually gets to the cell where you want it to get to, and by that point, the actual effect is meaningless. So we've got to consider that as well. So there's not a lot of evidence here to support phytochemicals. That's not to say that there won't be in the future. There's 20-odd thousand phytochemicals. This area is potentially rich in potential avenues for alternative treatment. But at this moment in time, there's not enough evidence to support their use. What happens when you change the composition of the diet? Again, this study here, reflective of the area. It's a meta-analysis, a rather systematic review. 28 full-text articles have been found. 6 were only considered good enough randomized controlled trials looking at PCOS. And you can see in this study, they've looked at various different diets. Low carb versus high fat. High MUFA versus high saturated fat. Healthy guidelines versus calorie counting. High protein, etc. The authors conclude, and again, the area is rich for an update. We need more studies. That even off these 6 studies, there's not enough there to really consider that we could suggest an optimal dietary composition beyond just calorie restriction in women to manage PCOS. So none of these were any better than the other ones. And the study lengths as well, very short. Okay, that's all interesting. But what happens when we start looking at other markers beyond just weight loss? So this study here, it's a review and our meta-analysis. I'm not going to try and pronounce the name on this. Looks at 19 randomized control trials, 727 patients, and they looked at multiple outcome markers, okay? So we've got BMI and we've got weight loss. That's interesting, we want to look at that, but we're also looking at markers associated with insulin resistance and glucose control for factors such as hyperinsulinemia, etc. So we've got HOMA-IR, we've got fasting blood glucose, we've got fasting insulin. We're looking at dyslipidemia, so we're looking at triglycerides, total cholesterol, HDL, LDL as well, total testosterone as well at the same time. And then looking at all the outcomes combined. And they've used a ranking, okay? It's something called a SUCRA score, okay? And the higher your SUCRA score, the higher the intervention seems to be for that particular type of dietary approach. And you've got different dietary approaches. You've got the DASH diet, which is a low salt diet. We've got high protein, low calorie, low carb, low fat, low GI, low protein, Mediterranean, low calorie, just a normal diet, and then using metformin, which is a drug which helps you regulate insulin resistance. The higher your score, close to 1, the more optimal your diet is likely to be. So if you get a score around about 40%, it's probably likely to be the true 40% diet. If you get a score about 50%, it's about halfway. If you get a score of 73% for like that low calorie diet, you're starting to edge towards, we're almost 75% sure that this is the best way to do it. And this is interesting. Again, when you go through this, what you see is, well, a low-calorie diet, consistent with the other approaches in the recommendation, is probably your best bet when it comes to just managing BMI. Low-calorie diet plus metformin is probably your best bet when it comes to managing weight loss. And again, I'm not going to go through all of these factors. You can have a look yourself. But when you combine all the outcome measures, what you see is the DASH diet and the Mediterranean diet come out on top as being the best approaches for managing all these symptoms, but there's some missing spots in here. And actually, none of them get as high as almost 70% with all the combined factors. Which brings us back to our guidelines, which is basically, there's no clear evidence of what is the best dietary approach to manage PCOS. Again, which means a diet which is consistent with popular public health guidelines, or evidence-based public guidelines, I should say, which promotes healthy eating and is in line with eating habits and what the patient potentially enjoys based on their preferences, is probably the best approach you can take at the moment. In terms of exercise, well, we know exercise is good for all these different reasons, okay? And general consensus is around exercise and what we should be prescribing is in line with the national guidelines, which is 75 minutes of vigorous exercise twice a week, at least, or 150 minutes moderate-based exercise multiple times a week. Some of that exercise should be strength-based lifting, and it's good for us for a whole host of reasons beyond PCOS as well. So it can certainly help us address hyperinsulinemia, glucose control issues, menstrual irregularity issues as well. And if you want to read more on this, you can read about this position stance from the Australian Institute of Sports Science. There's plenty of other topics that we can approach in PCOS and things to consider. Certainly this large document has got sections on all of these, and I'll leave you to look at them in your own time. But summarising now, PCOS is a condition that affects the follicles of the ovaries that may influence fertility, reproductive health, can lead to hyperinsulinemia, and is often seen alongside hyperinsulinemia and obesity, cause hyperandrogenism, which manifests in physical ways, hair growth, hair loss, for example. Management involves highlighting concerns around type 2 diabetes, cardiovascular disease, fertility. Screening should be involved, and general lifestyle advice around weight loss, healthy eating, etc. In terms of the research area, as I've just mentioned already, there's no clear consensus on a nutritional approach being better than other ones, although there's a dearth in research in that area. The area is rich for people to potentially go out there and do studies in this to try and find out maybe there is something going on there. I don't know. But certainly energy restriction alongside meeting the individual's needs, both in terms of their dietary preferences and general healthy eating advice, is what is recommended. Here's some useful links you can go and have a little look at in your own time. And finally, if you enjoyed this session, then there's a little QR code here. You can go and click on that. You can give me some feedback. You can tell me what you thought of this teaching session, how I should potentially do it different for you in the future, or maybe you enjoyed it just the way it is. Thank you for your attention. I'm Dr. Andrew Chappell. If you've got any questions following on for this, you can certainly catch me in one of the seminars, or you can email me at achappell@qmu.ac.uk. Thank you very much.